How's it going, everybody? It's the CDH Warrior and
the CDH Dad. Happy Father's Day to all of you listening out there. Thank you for joining us.
So, with that, let's roll the title.
Welcome back, everyone. Once again, this is the CDH Dad and the CDH Warrior, and it's Father's Day. We're doing our video on Sunday, just prior to Monday, which when we will broadcast this. But just once again, we do the disclaimer, but part of it is going to be the subject for today is we are not medical experts. We do not have a medical background. We do not have a background in psychology, sociology, any of the skills and sets that are typical in the hospital setting. More the focus that we have is what is real life family issues, how do you deal with those? And just to explain, our family has had two special needs issues. My son was born with CDH, congenital diaphragmatic hernia, and medical treatments, surgeries, all of the conditions there. And then a few years after that, we had my daughter, and when she was less than 2 years old, she developed aplastic anemia and ended up requiring a bone marrow transplant. So needless to say, we have gone through quite a bit in the medical field, both from the neonatal and then from the pediatric issues. And that's part of what we want to address in our discussions that we have here on Monday, and then I know my son does a special session for CDH.
CDH adults, more or less.
Adults and the long-term issues there. Part of what I wanted to address in today's session is just a question of medical knowledge. How much do you need to have? How much do you need to acquire? What are the things that are necessary? And I think one of the critical factors, and it kind of ties in with anything with parenting, is it's difficult to be a parent. Some of you have, a first-time child that may have a congenital issue or a neonatal issue or some pediatric issue, and you're having to address that. And if it's your first child, it's a whole new experience because there's a learning curve just to being a parent. But in the learning curve to being a parent with a child that has medical needs, then that becomes much more involved. If you have already had a child, so you understand at least the initial parts of parenting and those type issues, and then you get into the having a second child or a third child and having medical issues there, then it's a total flip, because a lot of what is considered normal are not things that you will be able to utilize or need with a special needs child. But you'll have to work on other skills. So it's one of the questions that comes up quite a bit of, okay, what are the milestones? What are the things you expect as a child is developing and growing? And if it's a special needs issue, you will find that a lot of their development and those type things go on a different curve. If you've got a child that's limited mobilities, not able to talk, not able to eat, those type of things, the body naturally takes over working on other developmental skills. So it kind of switches those things around. But part of what I want to discuss is how much is needed in terms of medical knowledge and medical background. And just to explain, my son is in his 20s, and when he was born, we did not know that he was a CDH prior to birth. It basically slapped us up the side of the head when he was born. And because of that, we had to very quickly come up to speed on a lot of the medical requirements and medical issues involved. The other was, prior to his birth, the survival rate for CDH was about 30 to 50%. So it was very low, and there was not a lot of readily available information. It was also one that at that point in time, the internet was just in its infancy. A lot of this information was not available. Uh, Part of what I wanted to bring about today is you have a lot of medical information that's available, a lot of resources available through the internet and some of the social media and some of the contacts, people that you can talk to. But it's a matter of, as a parent with a special needs child, whatever the condition may be, you've got to very quickly come up to speed to understand the terminology. Part of that is being that, your responsibility is that you are the primary caretaker for that infant, for that child. They're not able at that point to speak for themselves. They're not able to communicate the issues that are going on. So your role in this is to basically be the advocate and to be the caretaker and to be the communications link between your child and the medical professionals and staff that you're dealing with. And this will vary depending on your medical treatment situation and plan. In our case, when my son was born with the CDH, we were fortunate that we had a OBGYN who had studied under Dr. Kays, who was a specialist and just starting a program with CDH. So we had some understanding of that. In most cases, we're hoping that, you've been diagnosed prenatally so that you're able to get into some contact with medical professionals that do understand that. So very quickly you need to get with medical professionals who have a understanding of what the situation is and what the protocols available are, and be able to help in the communication with that. Just as a side note from our experience, my son was born June 1st, ended up in a teaching hospital within 24 hours. And there's a learning curve involved because he was at the later stages of the students, doctors who in training, who were going through their year of residency and internship at the hospital. They had 11 months in that time period. So they were fairly up to speed on a lot of things and a great learning. And I have to say that, they were very helpful in that, along with the professors and the doctors and the medical staff that was there as the instructors and professors for that. We were warned by our nursing staff that on July 1st it would be a major change, because on July 1st the interns and residents and the doctors in training that we've been dealing with to some extent would be leaving, and we would be starting with a new class. These are students who, yes, they've gone through medical school, they have their degrees, they have their training,
but they have no real world experience.
Right.
It's one, I was trying to figure out when to jump in.
Go right ahead.
It's one, the thing is, with most teaching hospitals, your session is July to June. And it's generally, there's about 2 to 3 weeks between each for the turnover for your residents. This is not specifically from my experience, but it's from what I've watched with other teaching hospitals. UT is an example, because UT is a teaching hospital.
Right.
It's one, from what I know, just from my experience, you really want to make sure if you're admitted to a teaching hospital, it's sometime between March and June. Because that's when you've got your residents that know the most. And
Right.
they're not just getting ready to leave.
Right. And a lot of the programs will spend a few months with different specialties. So you
Yes.
may have a resident who is there at the hospital, but they may only spend 3 months in the neonatology and NICU. Then they may go to a different area.
Yeah.
So, you go through some of this that you need to be able to handle the communication on that. The other is you're dealing with medical professionals, and medical professionals have different aspects of how they do their practice. In the case with CDH, we had a doctor who specialized in CDH. So he was going to follow that protocol and this case directly all the way through. In the case of my daughter, we were dealing with a hematology oncology group that was dealing with a very special aplastic anemia condition for a child, which is extremely rare. So their knowledge base itself and their understanding of protocols was limited.
Yeah.
So in that case, they would rotate every week or so within the group of the 3 doctors within that group.
Yeah.
So that meant that you were having to rotate through and help catch the new doctor coming in up on where things were. So this is where my wife was extremely good at pushing the buttons and those type of things. In the conditions with the residents, when a resident came in, generally she would say, you need to bring in papers and you need to explain what it is you're doing and give me details of what is going on. And this was a pushback on them. And many parents have problems pushing back on medical professionals. But you have to understand that you are responsible for this child. And you need to let them know that, yes, we know that you're a professional. We know that you are learning your practice. But it's also one, I spend most of my waking hours with this child, and I know more about what is going on. It's very helpful to have a notebook and keep track of all of the tests, everything that's going on, all of the reports that are generated. Ask the nurses to give those to you, so that way you've got a record. You can go back through and you can start learning some of what's going on.
Yeah.
Because your input and your resources are critical in the health of this child. It's also one of questioning the nurses. We tend to focus on the doctors and their capabilities, but the nurses, the therapists, the other people in that hospital and in that professional group can be great resources on what's available.
Yeah.
So these are the type of things that you need to be able to feel comfortable utilizing. And if there's any pushback or any issues with that, if you've got a doctor or a medical person that is basically the point person for the care of your child, as was in the case of my son, you utilize that person as a sounding board and you try and push from that point.
Yeah.
If not, then you may end up having to go to someone outside the medical group and go with a patient advocate or a caseworker or someone like that. In the case of my daughter, it was a matter of we actually had to get a group together. And part of this is our background and experience was much different than a lot of cases. It's all going to be different depending on your situation. We're all individual families, individual people. But I have an engineering background. My wife was basically an educator certified in STEM, so she had a scientific background. So we both had a basic technical knowledge of things, but trying to get up to speed on some of these things were ones that it took some help. But in my daughter's case, it was one that, because we had the doctors that were rotating, and there was not necessarily a person or a doctor who was following every step of that case, we had to very closely follow that case. And in so doing, what we ended up doing was we got with a patient advocate, a caseworker, and had the caseworker pull the different groups involved together to discuss what the plan was going to be. And in that case, it was a matter of, because my daughter was aplastic anemia, which basically requires chemo and radiation, and basically killing out the immune system in the body before you can do a bone marrow transplant. And then what to follow in the protocol after that. We had to get those professionals together in a room. We had to get the person that was going to be over the radiation treatment, the one that was going to be over the chemo requirements, and discuss with them, okay, what is the protocol that we're looking at? How does that apply to a less than 2-year-old child? Because there was not that much in the protocols there. What are your personal feelings on that? And I still remember my wife asking the doctor that was going to be in charge of the radiation treatments and the irradiation of the body, and asking, okay, the doctor was a female, had a young child. She says, okay, if this is your child, what would you recommend? And sometimes it's a matter of having to talk to the doctors. And I understand that from the medical standpoint, these doctors have to deal with a lot of real life situations, and they try to avoid being personally involved with that, because that can be a very psychologically gripping situation. I actually know a doctor who was a neonatologist, and after several years had to leave because it is a medical stress and a psychological stress that fits into your body and into your mind. So that's one that you have to deal with your medical professionals. But it's also a matter of, you have to work to understand, get them to understand that you need the knowledge. You need to understand the best standpoint for your child. And it's not just a matter of what can you pull as a page out of a book to do as a treatment for this child, but what is the best, and what can we tailor to this child? We were very fortunate in our case that both of our children, both of my kids are in their 20s, and as far as the medical and the health standpoints, in fairly good shape. The concern is, even after 20 plus years, is, okay, what are we missing? What have we not seen? What is hidden inside that body that we need to think about and address in the long term? So this is going to be a long-term journey when you have a child and they do survive. Is, okay, what do we do to not only help them survive, but how do we help them thrive later on in their lives? So that was part of the focus of what we had today. And I know you've got plenty of things to say, so I'll let you finish up with your comments.
I wanted to interject a couple of things. The first one was about protocols. When my sister and I were both in the hospital, protocols for this stuff were absolutely in their infancy. With CDH, I was the 15th patient David had seen?
I think you were the 26th CDH child that he had. And a couple of those prior to you were not successful.
Yeah.
And in your case, it was unusual because you had a repair by an outside doctor. So he really didn't have anything other than what he could kind of see and do x-ray and what he could read on paper, because he had not literally seen what was going on and going through that. So yeah, it was a unique situation there.
I wanted to point out something else with regards to Mary. And you can correct me if I'm wrong, but from my understanding, they were having to make up protocols on the fly because there was no protocol for this at the time.
Right. There was no protocol for her treatment for the irradiation and the bone marrow transplant, because it's a rare occurrence anyway.
Yeah.
And we're talking cases of one in a quarter of a million.
Yeah.
You know, so 1 in 250,000. So it's not like there was a lot of knowledge base to go from on that. The other was, you work very closely with your doctors. And in her case, it was one that she ended up with a infection with fusarium. And in that case, it was a matter of, we didn't know she was diagnosed. We didn't know that she had fusarium until several days after it manifested itself. Yeah. And I'll go through the anecdotal story on this one, which is, my wife had noticed that there were a couple of spots that were showing up on her skin. This was after she had had the irradiation and the chemotherapy and the bone marrow transplant, but before the transplant had engrafted. Yeah. So she had no immune system. And the question was, okay, she has some type of infection. We knew she had some type of infection. It happened to be on a weekend. So we're going through there. Well, the labs were running, but being able to go through this, it was fortunate that in the case when we were there, both children went to the same hospital, even though the hospital was hours from where we were.
In both cases.
In both cases, but my wife went to the hospital specialist in charge of infectious diseases. She basically went to the clerk for the transplant unit and said, "Is Dr. Skoda Smith available today?" And they said, "Yes, she is here." I said, "Could you page her?" And they paged her. Now, she had been a pediatric nurse at the hospital and then had gone back to school and gotten her medical degree and specialized in infectious diseases. So we knew her just indirectly, but we had contacted her previously. Yeah. So my wife talked with her and said, "Okay, what do you see?" And she says, "I know she's got an infection." I said, "We can do the blood draws, we can do the test, we can see what it is. It's going to take 48 to 72 hours to get the results back. And I will be honest with you, in 48 to 72 hours, she will probably be dead because of this. Because the infection would overpower her body before they could actually come up with a treatment protocol to do that." The two of them discussed this. My wife discussed this with the doctor, and she says, "I can go ahead and start a treatment of what I think it is, and then we can work on that." This was basically pushing the edges of accepted protocol at the hospital. Yeah. But that's what we agreed to do. So they started her on drug treatment. The other part of that is, at that point, we had a hematology oncology specialist who actually came from England and was trained there, and spoke to us and says, "There is a protocol that we had used. It's not accepted here, but what I would like to do is, since she does not have an immune system, and since the drugs are going to have limited impact and it's going to overtax her body in trying to fight this. What they did in that case is my wife and I both went through treatments to increase the white blood cell count in our bodies. And then we went in and had the white blood cells collected from us and then given to my daughter. Now, understand that white blood cells only last 2 to 5 days. They're not going to be there quite a bit. So it was a matter of trying to collect those and infuse those into her system so that we were providing the white blood cells for her body to be able to fight, and her blood system to be able to fight this infection. So between the protocol for the drugs and then this treatment, she was able to survive. But again, this is where, as parents, you become the caretaker and advocate in this. Is during that time period, her condition was quite grave. She was having a pulse rate of 150, which is astronomical for an infant and a child. And we did have to sign and put on file a do not resuscitate, because we knew that if her system failed, we could keep her alive with the instruments and the equipment, but
she wasn't going to
she was probably going to be brain dead from this. So we did have to take that factor. We were fortunate that the treatment protocols that we worked out with these 2 doctors were successful, and she did survive. But these are the type decisions that, as parents, you're going to be required to kind of work with your doctors with, and in some cases push your doctors and your medical staff that this is what we're going to do for the best case of this child. And if there's problems there, then you need to be comfortable in stepping up in the system and telling other professionals within the hospital, this is what we need to do. So we kind of got off a little bit from what I was wanting to discuss. We kind of still stayed on topic. But once again, we do appreciate your input on this. Any feedback, again, like I said, this is not from a medical standpoint, but this is from a concerned parent who has been there. And as we described, basically in both cases, we've been to hell and back with both of our kids. And it is a very trying and taxing endeavor, both physically, mentally, psychologically, spiritually. But these are things that, as a parent, you're going to have to make those decisions and utilize your best knowledge and judgment and the available resources you have and the people you have within your circle to help you. So, for the CDH Dad
and the CDH Warrior,
thank you very much for joining us.
have a great day.